Alright guys, so this is the third video in the series. This one mainly covers defense mechanisms. Make sure you watch all the way until the second to last video. The second to last question in the video was one that comes up on almost everybody's exam. So make sure you know the difference between, I think it was the avoidant versus schizoid, but wait till you get to that question, very, very important. Otherwise, if you find any questions out there that are difficult, please email them to us and we'll see if we can get them out there for you.
All right, it says, a medical student just finished their USMLE and is nervous about their performance. They decide not to think about the results of the exam until the score arrives 3 weeks because worrying about the exam won't change the outcome. They are delighted when they receive their score. After the examination, should the student exhibit what defense mechanism? So if we go look through these, you need to know the mature defense mechanisms, okay? You got to know the mature ones. SASH. It talks about sublimation, okay, altruism, suppression, okay, and humor. Now, sublimation is like you're going to replace it. You know, you're going to do something great. Yeah, I say great, but you know, sports are a good example. You're going to, instead of being negative, you're going to turn that into some type of positive reaction and be like you excel in sports or work or anything. And then altruism is, you know, you have these guilt feelings, but then you're probably going to be more generous. It's the person who gives back to the community. Suppression is going to be the voluntary, okay? That's the key word. It's the voluntary withholding. Okay, and then humor, just like it sounds, you're just going to use humor to kind of de-stress. Okay, so in this situation, this person, it sounds like she voluntarily said, I'm not going to worry about this until because it's not going to change the course of fate. So she used suppression. Now you need to know with 100% certainty that they're going to put in the answer choices suppression and repression. But the repression is going to be the involuntary kind of withholding of the memory or the, you know, the stressor. Suppression is going to be voluntary. Repression is involuntary. This is the person that says, look, I don't know, I don't remember. They would just want to absolutely forget, and that's more of an immature defense mechanism. But the mature ones, you better know SASH. Now this one says, a 22-year-old woman who was recently admitted to the psychiatric ward after attempting to commit suicide by overdose of Benadryl is being seen for follow-up by her primary care provider. While speaking with the provider, she states, "You're the only person who understands me," and feels that the other physicians and nurses just don't like me. She is demonstrating what defense mechanism? Now, what is she doing? She's taking one group and saying, you're all good, and the other person's kind of all bad. She is splitting, right? Now, just as sure as the sun rises, you better be familiar with splitting is associated with borderline personality disorder. And I can tell you that step 1, step 2, step 3, love borderline personality. This is, everything is kind of, you know, black and white, all good, all bad. You know, they can be hypersexual, the relationships start real intensely, and they fizzle just as quickly. But borderline personality, you got to be familiar with, and it's associated with splitting. The other thing that I want you to really focus in on is projection versus displacement. Projection is you're shifting thoughts, you know, onto someone else to make yourself essentially feel better. But again, it's more, you're not physically doing this. You're kind of saying something. It's like someone who is a cheater in a relationship. You know, they'll say, oh, well, you know what, you must be cheating, you know, and they kind of threaten somebody else, but they kind of like say you must be doing that, when in reality they're the ones that are cheating. That's projection. Now displacement, you can see the difference between the two. This one has an A in it, right? Because I want you to remember that the A means anger. When someone's taking out the anger on something, like they come home and they throw stuff around the house because they got a bad day at work, that's displacement. There's always a sign of anger. Again, projection, you're kind of throwing your thoughts onto someone else, and then displacement, you're going to see the anger. Sublimation we talked about, that's it's a mature defense mechanism. You know, transference is like when you have, you know, there's a patient, and then you have the therapist. When the patient projects onto the therapist, meaning, you know, you remind they start treating the therapist as like their father, their mother, as their parent. That's transference when it goes in the direction from the patient to the provider. When it goes back from the provider to the patient, where they think this person's acting like maybe an ex or maybe like a child of theirs, that's called countertransference. And then intellectualization. That one example that they always like to do with that one that you see in the books is like, you're at a funeral and all you can think about is how much the funeral may have cost as opposed to why you're actually there. Now, this one says, a 47-year-old woman remembers being sexually abused as a youth by her older brother. She draws from her experiences to express intense emotions in her work as a lawyer. This use of her childhood experiences is most indicative of which of the following coping mechanisms. Now, it sounds like this is a mature way of doing it, right? And that goes back to our SASH, kind of acronym there. And so, she did something and she made the most out of it. She redirected her energy and put a lot of her focus into work. And of course, we're gonna call that sublimation. Remember what we said? Repression, it's the involuntary withholding. Denial is just saying, hey, yep, didn't exist. Projection, remember, you're pushing your thoughts, that whole cheater mechanism. No, I'm not a cheater, you must be cheating. They're projecting it onto someone else. Regression is just basically it's an adult who regresses to like a childlike behavior. They're regressing to an earlier age. Displacement has what? Has the A. What does the A stand for? Anger. They got to have that anger in there. And then dissociation, basically that just means like there's a drastic personality change, and that's where you see that dissociative identity disorder, which is multiple personality now. Very, 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 very rare, but that's just a drastic personality change. Not really seeing too much on questions on that. But on this situation, the correct answer is going to be D, sublimation. This question, probably would have been in the other video, but it's, I guess anyways, we need to know it, bottom line. So, which gene mutation may be responsible for this neurocognitive disorder? Okay, well, here they are. I look at this presenilin, ApoE4. There should have been like an ApoE2 in here. Long story short, it says, Mr. Bill is 79 years old, okay, who has lived in an assisted living facility for the past 6 years. He requires assistance with most of his activities of daily living. After losing his wife when he was 65, his family members observed him slowly declining in day-to-day functioning. So he's got all the makeups of Alzheimer's here. He is difficult to remember he has difficulty in remembering the names of his grandchildren and lost his driver's license after he drove across state in the wrong direction when trying to find his way home. He takes no other medications other than his ibuprofen and arthritis. His son, who is now 54 years of age, is now showing similar cognitive deficits as his father. Which gene mutation may be responsible? So they're saying, look, he's got Alzheimer's, but now they're saying his son, at 54, is a little bit on the young side. Because typically when we're looking at these neurocognitive, the basic ones, naturally it's like 65 and older is when we say, okay, now we might expect it, okay? But this guy's having it at 64, so that's like an early onset. And we have to know that the early onset is going to be the presenilin 1, presenilin 2, and amyloid precursor protein, which is on chromosome 21, right? Because why is that important? Because who has the dementia at an earlier age? Who's got 3 of these guys? Right, the Down syndrome. So early onset, you better be knowing that it's going to be the presenilin 1, presenilin 2, and amyloid precursor, right? Look at the answer choices. You needed to know it's just more than that. Now, the E4 is going to be late, right? And then E2 is going to be protective, right? Protective. Alrighty? Got to know that. This one says, a 17-year-old student is brought to his family physician by his parents after failing several classes in school. The physician discovers that the patient has been abusing marijuana and alcohol. Upon hearing this information, the physician, whose teenage daughter also abuses drugs, is upset and asks the patient's mother if she feels like slapping her son. What defense mechanism is he using? Now, he's not acting out. Now, I'll say this. He's not acting out with anger. He's not slapping anybody, right? So we're going to, and displacement's not on there because that's off the table. And don't jump on that just because he's mad. He's not doing anything physical to warrant displacement. he's actually shifting his thoughts onto the mother, telling her to do something like that, or how do you feel? He's shifting his focus. He's avoiding his guilt feelings by doing this, and of course we call that projection. Okay, acting out is just like it sounds, kind of like a kid. Regression is, again, you're going back to an earlier state. It's the adult who's acting like a child. Repression, again, is the involuntary withholding. Sublimation, that's that mature defense mechanism where you replace your unacceptable feelings with a similar action. That's a person who's like a sports athlete that excels a lot or excels at work. And then a splitting, all good, all bad, you better associate that with borderline personality disorder. So the correct answer on this one's going to be D, projection. This one says, a 5-year-old male is examined in the emergency department and found to have a well-demarcated round burn mark on his thigh. When asked about the burn mark, he says, "This happened every time I'm bad. Which of the following is the best next step in the management of this patient?" Now, you better, with 1,000% confidence, if you're not going to choose A on this one, you better have some great reason for doing so. Anytime there's a child abuse issue, you better be saying, I'm going to contact Child Protective Services. You're not going to talk about any of this other stuff about talking to the parents anymore, ask the physician to witness stuff. Now, so contact Child Protective Services anytime you see a question like this, okay? Just do it, because chances are you're going to see it on all the STEP exams. Now, from a genetic point of view, right, that one we see sometimes is that osteogenesis imperfecta, right? The like blue sclera, fragile bones. But man, it better be just clear as day that it's that for you not to choose this answer. Okay, so keep this on your radar, but you better be 1,000% sure if you're not going to choose this one. Okay, this one says, looking at my answer choices, looks like it's some neurocognitive disorder. Mr. Davis is a 54-year-old male with unremarkable past medical or psychiatric history. His family brought him to the emergency room after increasingly erratic and overt behaviors over the past 3 years. Now, for 3 years, and he's only 54, Mr. Davis works in accounting and has been having more difficulty at work with his peers. He is uncharacteristically rude towards customers. At home, he is very curt. Again, that's kind of rude and short-tempered with his wife and kids. His wife now does all the finances due to his behaviors. At work, he was accused of making sexually inappropriate. This guy's got behavior issues here, obviously, and it's uncharacteristic. There is a family history of a brother with similar symptoms, so there's a genetic component. Upon evaluation, there's no indication for vascular compromise. Okay, so if there's no vascular compromise, and that basically rules out, kind of a stroke or anything, they're just leaning away from this vascular disease or mental history such as depression or bipolar. What is the most likely diagnosis? Now, probably on the probably on the USMLE, they're probably going to say CT scan was unremarkable, maybe except for some atrophy, perhaps. But it's going to be unremarkable for the most part. With this guy's got behavior issues. Now, remember what we had talked about. You got PICS, you got Lewy body. These are our main players, and then you got Alzheimer's, right? And PICS is going to be the frontotemporal dementia, and that's going to be the personality changes. Okay, personality changes. Lewy body better have some visual hallucinations going on, which this guy does. Hallucinations, okay? And then there's not enough evidence to support that he's got HIV or anything like that. There's just nothing in here that leads us in that direction. And normal aging, again, get used to that being an answer choice, but at 54, you shouldn't be having these you shouldn't have having these changes at all, much less at 54. And Alzheimer's is a diagnosis of exclusion, but the best answer for this one, and they didn't come out and say PICS on this, but they call it frontotemporal, is going to be answer choice A. Okay, but know this: PICS, frontotemporal, personality changes; Lewy body, visual hallucinations; Alzheimer's, diagnosis of exclusion; and remember, ApoE2, protective; ApoE4 is late, and then you got the whole presenilin 1, presenilin 2, and amyloid precursor protein, chromosome 21. Okay, and then this one says, 67-year-old man is brought to the emergency department because of a 1-week history of confusion, disorientation, erratic behavior, delusional ideas about his neighbors, and incontinence. Mental status elimination on arrival is difficult because he does not want to engage in the interview process. Which of the following is most likely diagnosis? Okay, so 1-week history. Remember what I said, when you see an old person, you better be differentiating between dementia versus delirium. Now, delirium, sudden. Dementia, gradual. Okay, this is 1 week, so it's sudden. It's going to be delirium. Now, so there's your answer choice, and boom, you can move on from there. As you evolve on this in your studies, there's that acronym called watch death, and you don't have to know this for step 1, so forget it if that. But if you want to know how to work up delirium when you get into residency and stuff, there's a good acronym. So when you have this, you can rule out all these potential causes. But typically in a 67, you're looking at probably urinary tract infection or some type of infection, and then they clear. But if it was gradual, we would do our dementia kind of workup, and that again we would have Pick's disease, personality changes, Lewy body, which is going to be the visual hallucinations. We'd have HIV. There's got to be some data to support that. Parkinson's, it's going to have that type of the gait, and that flat affect. And then Alzheimer's is going to be your default. So you can always go through theirs. And the best answer here is going to be the delirium. This one says, you're seeing his 37-year-old Caucasian male for a routine follow-up for blood pressure during 1 week. During one of the most recent visits, he reported that every time he gets into an argument with his wife, he feels the need to break something. Right? He's doing something, and he's what? He is angry. Okay, and we said when you're actually doing something physical that's very angry, you're going to be jumping all over displacement because there's with the A. Okay, to get it out. Yep. So if I said splitting, you're going to say all good, all bad. Borderline personality disorder. Okay, projection is you're shifting thoughts. Right? That's the cheater mechanism. Oh, you must be cheating. Sublimation, that's the mature defense mechanism where someone becomes good at sports or good at their work. And again, transference is where the patient puts their thoughts, he treats the therapist as though they're a parent or, or a spouse or something like that. Okay? Now, this one says, 79-year-old female lives in an assisted living facility with dementia. Is paranoid and complains of she's seeing children walk through walls. Seeing children walk through walls. That's kind of a visual hallucination, right? Now, how long has this been going on? She's been living at the facility for several years after inappropriate behavior at her original home. She had accused neighbors of stealing from her and was calling 911 frequently. Her physician started Risperdal 1 milligram at night. Her nurse indicates that she appears to be more sedated and lightheaded than normal. Her movements are more slow and rigid than normal. Okay, so we worry about NMS, right? What is the most likely cause of her major neurocognitive? So they're not saying what's the cause of this rigidity. They're saying what's the cause of this. She had a history of seeing kids walk through walls, and seems like she had these problems that are ongoing for quite some time. When I say visual hallucinations, you better be jumping all over Lewy body. There's not enough data to support vascular dementia here. There's nothing about history of strokes or multiple kind of the roto-rooter jobs or anything like that. And then Huntington's, as we know, that's a CAG kind of a repeat, autosomal dominant. Medication side effect, well, the medication, could it have caused the rigidity? Yes, but is that the cause of this major neurocognitive kind of dementia? No. Okay, she's had this probably a long time. Visual hallucinations, again, jump on Lewy body. This one says, a 27-year-old woman has sepsis that resulted from self-inflicted wound to the forearm. Some of the staff feel emotionally attached to her. Others describe her as a difficult patient. She is labile and impulsive. She has a history of many psychiatric hospitalizations and abuse of multiple drugs, which the following is most likely psychiatric disorder. Again, she's splitting, right? Some people are all good, all bad. You better be jumping all over borderline personality disorder on this, okay? And, adjustment disorder, remember, that's where the stressor is within 3 months and it's just an exaggerated response to it. Anxiety is more just that nervousness. Generalized anxiety has to be at least 6 months. Bipolar, you live in Depressionville, but then you have these elevated moods, some extreme and sometimes not so extreme. And then schizoid, the thing about schizoid, and it's very important, is you need to differentiate schizoid versus avoidant. Okay, schizoid versus avoidant, and the schizoid person says, I don't like to be around others, and they don't really care whether they're there or not. The avoidant person says, I don't really enjoy being around others, but they want to. They do care, okay? both these people have the same outcome. They don't do well. They don't want to be around social situations. But the avoidant person really wants to. He's afraid of being rejected. The schizoid is the guy that lives out, probably in the middle of nowhere and doesn't care whether he's around people or not. But you better know with 100% certainty. Every time I talk to somebody about this exam, that one usually comes up. Okay, but in this situation, better know borderline personality. Okay. So speaking of that, it says a 24-year-old man comes to the physician's office for a health maintenance examination. He mentions that he is having difficulty meeting new people at graduate school because he feels inadequate. He has always had difficulty socializing with people because he feels that they will make fun of him. He is sensitive about the negative criticism, and the most likely personality disorder is which of the following? So again, here's a guy, he wants to be social, right? The guy wants to be social, but he feels inadequate. I always think about like this. It's always like the good guy in the office, right? He just doesn't have the skills, and I just call him Avery, okay? Avery's the guy in the office. I put a face to it. Nice guy, but he is the avoidant. He wants to be the social guy, but he just feels like he's going to be he's not going to make it. He's going to be rejected. So this guy wants to meet new people. He says he's having difficulty, but he's afraid of people making fun of him, and so that's going to be the avoidant person. Now, again, if this guy didn't care, then you would just call him the schizoid, right? They don't care if they succeed or not. Now, these other ones, antisocial. For that one, here's the deal. I want you to remember that you have the thing called oppositional defiant versus conduct disorder versus antisocial personality. Okay. Now, the oppositional defiant is just that, because these are both for kids, right? Less than 18. Oppositional defiant is just the kid in the classroom who likes to speak out. He likes to be the class clown, kind of get in trouble, but he doesn't break the law. Okay, that's this guy. The conduct disorder kid is the one less than 18, but he's breaking the law. He's a truant. He's skipping school. He's breaking into houses. He could hurt animals, all that kind of stuff. That's the conduct kid. So the difference is oppositional defiant, he's just a little bit bad. But the conduct disorder kid, he's kind of bad to the bone. Now, once this conduct kid turns 18, congratulations, you're now considered antisocial personality disorder. So you can't make this diagnosis till they hit 18 plus. But conduct and antisocial is kind of a little bit of a transition there. But again, oppositional defiant, just a kid that likes to speak out a little bit too much in class. Now, this one looks like it could be our last one here. It says, 26-year-old female comes to your family practice asking for the names of a good plastic surgeon in the area. She says, I still hate my ears and I want to get them fixed, she states. The patient states that her ears have bothered her for the past 6 years. She spends about 1 to 2 hours per day trying to improve the way her ears look with different hairstyles. Upon exam, usually the patient has unremarkable ears, not ears. The patient most likely has which of the following. So, she has this perception that she has these flaws, right? But upon exam, there are none. And at least from our perspective, this goes with like the nose, it could be the ears, it could be the eyes, and so that's considered body dysmorphic. But those people believe it just as much as the sun rises, that there is a flaw with that. We talked in the other video, conversion, that's more of a neurologic, right? It's more of a neurological disorder. The CNS, that's the part that's under control, involuntary control. Hypochondriasis, they're more concerned about the diagnosis than the symptoms. They're preoccupied with having some type of disease. Munchausen, remember we said that one was going to be, it was like a primary, it's a conscious choice, but it's a primary gain, that they make themselves sick, okay? And then malingering, that's going to be more of a secondary gain. There's got to be something in it for them. So, guys, I hope this helps, and we will see you in the next video.